Good morning. Good morning, good morning, good morning, good morning. And welcome to another exciting session of continuing medical education brought to you by the Department of Continuing Medical Education. This morning, we have a very exciting lecture lined up for you today, a very common topic. We hear about it all the time, we see it all of the time. And today, we're going to update our knowledge on exactly how to treat it. But before we begin, as we usually do, let us say a quick word of prayer. Father God in heaven, we come before you this morning, thanking you for this another day, thanking you for another opportunity to learn together and to share in this moment of teaching and reflection. We pray that you be with us and that you open our minds, that we receive the wonderful information that will be brought forth to us. This I pray in Jesus' name, amen. So, our guest lecture this morning is Dr. Harinoor Mann. And I'll just give you a little information about him. Dr. Mann is a graduate of the Government Medical School in Patalia, India. He completed an internship at the Government Medical School as well as Allegheny General Hospital in Pittsburgh, Pennsylvania, in internal medicine. He also did a residency at Allegheny General Hospital in Pittsburgh, Pennsylvania, and advanced neurology. Dr. Mann is an associate professor at the Northeastern Ohio Medical School and is also a staff neurologist at the SUMMA Health Neuroscience Institute. He enjoys basketball as well as golf. So please join me in welcoming our presenter this morning, Dr. Harinoor Mann, discussing headache disorders. Dr. Mann, feel free to share your slides and begin.
Hey, thank you so much for the kind introduction. Are you able to hear me okay?
Yes, we can hear you perfectly.
Okay. And it's very exciting to meet everybody and able to share some knowledge on headache disorders. I'm going to go ahead and share my screen. Okay. Screen. Okay. Are you able to share? Are you able to see my screen?
We can, but could you put it in the larger
Yeah.
form
Yes.
for
I was
us?
just making sure. Okay. All right. So this is my disclosure slides. I'm just going to go ahead with the presentation so that we can cover as the most we can in this 1 hour of presentation. And in terms of agenda for today, what I will talk primarily is we'll focus on primary headache disorders. We'll talk about migraines. That's going to be the biggest chunk of our presentation today. We'll also talk about other primary headache disorders, including tension type headaches, trigeminal autonomic cephalgias, other benign headache syndromes. We will also talk briefly about headaches in pregnancy. And then we'll quickly spend a few minutes on talking about some secondary headaches as well. We'll go ahead talking about migraines, starting with migraines. I think it's very important to understand the epidemiology and the extent of how prevalent migraine is. There's about 1 billion people and, that suffer with migraines. And talking about how it impacts people's life, there's about 30% of those patients who have at least missed 1 day of work or school within a 3-month period. It's a fourth leading cause of ER visit and one of the biggest causes of disability. In all age group, it's actually the third largest cause of people going on disability in the world, and second largest cause of young women going on disability. And the prevalence can be as high as 27% in women between the age group of 30 to 39 years of age. I did talk about this slide, that how prevalent and what's the burden of migraines all over the globe, that it's about the third leading cause of disability and the second leading cause of disability in young women. We'll talk about some etiology of migraine disorders. There can be some genetic inheritance, which poses about like a threefold risk of getting migraines. It can be familial hemiplegic migraines, which can be associated with changes in the voltage-gated calcium channels, voltage-gated sodium channels, and sodium potassium ATPase genes as well. There are other genetic disorders which can be associated with migraines, included MELAS, which is mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. CATASIL, cerebral, which is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It's associated with migraines and stroke in younger patients, and also seizures a lot of times. There's another rare genetic disorder called RVCL, retinal vasculopathy with cerebral leukodystrophy. But those are the biggest ones when it comes to genetic disorders which are linked with migraines. But there are a lot of other triggers as far as the etiology is concerned. And I'll quickly talk about those as well. There's about as far as patients who experience migraines, 80% of them state that stress is one of their triggers. There are some hormonal changes which are related with migraines. There's about 65% of cases can report some issues, so some worsening migraines during menstrual cycle, ovulation, or pregnancy as well. Now there is also other factors, including meals or skipping meals, or some different forms of food which can be their triggers. Sleep, weather changes, alcohol, smoking, and in some cases, some triggers can be some exercise and sexual activity as well. Then we'll jump on to the pathophysiology of migraine. There used to be a vasoconstriction, vasodilation theory, and that's since been debunked. And I think we are seeing more role of the trigeminal system in the pathogenesis of migraines now. There are multiple, sorry about this. This light is a motion sensitive, so sometimes it just goes dim. So there are multiple primary neuronal impairments in pathogenesis, which causes a series of intracranial and extracranial changes. What happens is there is an activation of afferent coming to the trigeminal ganglion, which in turn releases some pro-inflammatory mediators and spreads this activation towards the trigeminal fibers around the pia mater vessels. And what happens with this is there's an inflammation in those pain-sensitive meninges, which in turn activates nociceptor in the trigeminal system and release of substance P, calcitonin gene-related peptide, and neurokinin A. More recently, in the last few years, we've been seeing, that the calcitonin gene-related peptide has been that has been come up in pathogenesis, and there are so many new medications that are focusing on this molecule, and that's very exciting. I'll talk about different phases of migraine. So there is a prodrome phase, and about 77% of the patients can experience this between even 1 to 2 days prior to the onset of migraines. And a lot of people, they don't even know that they have this prodrome phase, and it can include symptoms like yawning, mood changes, lethargy, some neck stiffness. So what we think is there's a big association of the hypothalamic system, and that's what causes, and its relationship with the limbic system, that's what causes these mood changes, and there's yawning and arousal changes, and there's also some association with the thalamocortical system as well, which basically can cause a lot of sensory changes, a lot of neck pain, neck stiffness during this prodrome phase. Next would be aura phase. It may or may not be present, and we will talk about this aura phase in a short while. Basically, there are changes in the cortical function, blood circulation, and neurovascular integration, which occurs in 1 in 4 patients with migraines. Then there's a headache phase. And followed by a post-drome phase in which patients can experience some positional characteristics, some movement, headache with changes with movement, and just some dull pain or dull ache in the area of the previous migraine. We'll jump to the different types of migraine. The most common one is migraine without aura. And the diagnostic criteria includes having at least 5 episodes of a headache which last for about 4 to 72 hours. Now, it's very important. The timeline here is very important. And when I ask my patients, we always tell them, okay, how long does a headache last for before it completely goes away by itself? If you don't take any ibuprofen, Excedrin, or any over-the-counter or any rescue medication, how long would it last for? And the reason why it's so important is because it distinguishes migraines with a lot of other primary headache disorders. And sometimes, in real life clinical scenarios, it can be very hard to distinguish these headaches from each other. And along with lasting for about 4 to 72 hours, these headaches should have at least 2 of the following 4 characteristics. It should be one-sided, unilateral, pulsating or throbbing characteristics. It should be at least moderate or more in severity. And it should cause some avoidance of routine physical activity. And this is somewhere, we have to ask about the history in more detail. A lot of patients will say, oh, it doesn't bother me. But, when you ask them, okay, if you were not working, you were at home, you could do anything you want, what would you want to do? Most of these patients will say, I would want to just lay down, I want to take a nap, or I just want to not do anything. So, sometimes we ask them, okay, do you avoid any physical activity? And they might say no, but then you go in more detail, and then you find that they actually do. Another thing, there should be at least one other feature. It should be nausea and vomiting. But if they don't have nausea or vomiting, they need both photophobia and phonophobia. And that's, again, another thing we have to ask the patients in detail, like, because a lot of my patients say no to these symptoms. And when you ask them, okay, what do you do when you get a migraine? They'll be like, okay, I just go to my room and I just close my eyes, So that suggests that, they do have some photophobia and phonophobia when it comes to, this associated symptoms with migraines. We'll talk about migraine with aura next. So again, this one needs at least 2 episodes. And when it comes to aura, we have to make sure that these symptoms can be positive or negative symptoms. Positive symptoms, which means, they will have some visual, it could be visual symptoms that we can see, can have like scintillating scotomas, bright lights, darkness. It could be a lot of different things when it comes to visual auras. And then there can be some other symptoms like numbness, so tingling, paresthesias. That's another positive symptom as well. What other brainstem symptoms, which include tinnitus or double vision. So they can have some brainstem symptoms as well, or they can have negative symptoms like loss of vision or weakness. So you can, but all these symptoms should be fully reversible. And these aura symptoms need at least 3 of the following 6 characteristics. It should gradually spread over more equal to or more than 5 minutes. 2 or more aura symptoms should be in succession. Each aura symptom should last at least 5 to 60 minutes. Should be one of the symptoms should be unilateral. One of the symptoms should be positive. So we don't need all 6. We just need 3 out of these 6. And then within 60 minutes of aura, there should be a headache that follows it. Then we'll talk about another very common form of migraine we see in our office is chronic migraines. So important thing to remember when we diagnose somebody with chronic migraine is the number of days. So they need to have 15 headache days. And a lot of times I see patients downplay their number of headaches just because somebody with chronic migraine, they're used to headaches all the time. And what will happen is, they just start counting extreme, bad, severe headaches. So it's important to ask them, okay, how many days do you have any pain in the head? And you'll be surprised, how a lot of these patients, they go from like, oh, I have 6 headaches to like, I have 16 or 18 headaches, or I have a headache every other day. And you also need to have these headaches going on for at least 3 months. Um, and that's how you diagnose them with chronic migraine. We'll talk about acute migraine management. And the first slide here, it's very important. And I think it's, in medicine, and at least in clinical setting, we forget about these medications. A lot of times people have already tried this. They might tell you they've tried a Tylenol, or um, they have tried a Tylenol or some kind of NSAID, but it's very important to understand the dosing here. And these dosings come with a level A evidence. And sometimes patients will just take a Tylenol or acetaminophen, 500 milligrams. And, we have to tell them, okay, you got to try, especially important in pregnant patients where you cannot use a lot of other medications. You got to try 1,000 milligram at least, and that's proven to have pain freedom. And pain freedom is another important thing here. Most of these headache, the research was done around the primary endpoints has always, most of them has been pain freedom, which means there's no pain whatsoever in about 2 hours. So with Tylenol, about almost 1 in 4 patients will have pain freedom. And there are other medications like aspirin 900 milligrams, diclofenac 50 or 100 milligrams, ibuprofen 200 or 400 milligrams, and naproxen. All of them have a level A evidence. But it's very important to understand that, we don't want to use these NSAIDs in patients with cardiovascular disease, patients with renal disease, or patients with chronic migraines. And we have to tell them, like, you have to make sure that you do not take 10 to more than 10 or 15 days of, you don't take these over-the-counter medications for more than 10 or 15 days a month. Or that can cause rebound headaches or medication overuse. Now, I see a lot of this usually happen in ER setting, where patients get discharged. Patients come to the ER with a migraine. They get discharged with a 10-day, 15-day supply of Furoset and opioid. And it's not that these medications do not work. They do work, and they do have their role in specific scenarios. But we really avoid these medications because they have a very high risk for medication overuse or rebound headaches. So these medications should be avoided. I'm not going to go into detail with triptans. This is just a slide if somebody wants to just have like a whoop, want to take pictures, or just have this slide with them so they can look back whenever they're treating somebody with migraines. But I will touch on a few things. Sumatriptan, one of the most used medications, comes in 3 forms: oral, nasal, and subcutaneous. Where the subcutaneous forms is the most efficacious, more than the nasal, and then more than the oral. And I don't see this being used a lot now, subcutaneous injection, especially with newer medications that have come out. But we'll talk about why knowing this and knowing what all options you have is very important. The other things I want to talk about, especially with these 2 other kinds of triptans, frovatriptan and naratriptan. These 2 triptans have very long half-life. And why it's important is sometimes I use it as a mini prophylaxis. So patients who have catamenial migraines during their menstrual cycle, I would sometimes use this as a prevention. So you usually start they will usually start this triptan, naratriptan, a day before their menstrual cycle, or 2 days before their menstrual cycle, depending upon, individualizing it based upon patient to patient. If somebody migraine starts 2 days before their menstrual cycle, we'll start then, we'll continue it for 6 days or so, and use it as a mini prophylaxis. You can also use it in other situations. Sometimes I have a few patients who have migraines close to their ovulation, and as long as they can track their menstrual cycle, we'll use this during their ovulation and not during the menstrual cycle. Sometimes I have patients who have a big life event, they have a wedding or something to go to, and sometimes we use this as a mini prophylaxis for them as well, because it's not that expensive, and you don't have to be there on it for long, and this can be used as a mini prophylaxis. um, the reason why I said it's so important for us to know all our options, because of this data. On a meta-analysis, they found that the pain freedom with triptan was 42 to 76%, which is a very good number. But unfortunately, a lot of patients have side effects like nausea, dizziness, somnolence, paresthesias, chest tightness, flushing, dyspepsia, and that's the biggest thing that I see with my patients, and they cannot tolerate. But again, understanding that we have all these different options, and they have a very good pain freedom number, 42 to 76% in patients. I think it's very important. Another thing that's important is understanding when you cannot use a triptan. I would not recommend in somebody with history of any coronary artery disease, history of any cerebrovascular disease, uncontrolled hypertension, peripheral vascular disease, any cardiac arrhythmia, ischemic bowel, or hemiplegic migraine. So it's important to understand it's hemiplegic migraines, and not just. I see this word thrown out a lot called like complex migraines. And a lot of people still use it. I don't use that word because it's more confusing than anything. People with any stroke symptoms, like people with the sensory symptoms, or any unusual symptoms, and people just start calling that complex migraine, understanding that triptans are not contraindicated unless it's a hemiplegic migraines, which means you become pelegic on one side with a migraine. These are newer medications. I won't go into too detail, but there's something called Dieten, called Lesmeditin, which came out, I think, in the last 4 or 5 years. It works on 5-HT1. It's a 5-HT1 agonist, so it does not work on the 5-HT1B like triptans, so it does not cause vasoconstriction. So it can be used in somebody with cardiovascular risk, but it has the biggest side effect is drowsiness, and then there's a potential of abuse there, and there's an 8-hour driving restriction. But look at this number. There's a pain freedom in 28 to 39%. That makes you think, okay, it seems like it's not doesn't work as well as triptans, but again, these medications, the newer ones, they don't have as many side effects, so we use them a lot nowadays as compared to the triptans. There are other newer medications called ibrogepant, rimegepant, and zavegepant, which is a nasal spray. But again, the numbers, these, everybody's talking about these medications, how great these are, which is right. They're very good medications. They don't have any significant side effects, like we talked with about the triptans. But look at these pain freedom numbers, right? 20% pain freedom numbers, 24% in that spread. So not as good as, we looked at that meta-analysis number of up to 40 to 76%. Next, we will talk about some neuromodulation devices. I do not personally use most of them, other than this last one called a Nerivio device, which is this device which you wear on the arm. I have some patients who are pregnant which would use this, and they don't want to take any medication, which is fair. And look, in research trial, there was a 37% pain freedom when used on the arm, within 1 hour, for 45 minutes, within 1 hour of onset of the onset of migraines. So yeah, not outside of pregnancy, I don't use it a lot. Not had any great benefit outside of pregnancy with this device, but still, it's an option. Other options are this Cephally device, which also had 39% pain freedom. This vagus nerve stimulation, which did not meet its endpoint, but it still helps with decreasing the headache. And this external trigeminal nerve stimulation, uh, which did not, it decreases the amount of pain, but didn't achieve pain freedom endpoint. So out of all these, I typically use this one for some of my patients. We'll talk about migraine prevention. And I think the take home point from here should be the dose, especially the dose. I see a lot of patients trying these medications at a low dose and just move on to the next medication and the next medication and the next medication. I think it's very important to understand the dose, the dosing, and it's this dose that had this level A or B or whatever evidence that each one of them had. I use amitriptyline a lot in migraine. Sometimes I use it as a twofer. I will ask them if they've had trouble sleeping, if they have other mood disorders, and I might prefer this than other migraine preventative medication. So that can be helpful. Nortriptyline can be used instead of amitriptyline for due to lower anticholinergic profile, but it's not studied enough to have a clear level A or B evidence. And venlafaxine can also be used. Um, and I rarely use Cymbalta, but there is some use in that as well. We'll talk about some antidepressant medications, especially beta blockers and calcium channel blockers. Beta blockers is one of my most favorite medications for migraines, given the safety profile that they have in pregnancy. So that's a medication. I use that a lot, and you can use metoprolol if they have history of asthma, or you can use propranolol if they don't have history of asthma, since it's non-selective beta blocker, and metoprolol is cardioselective. And then talk about verapamil. Verapamil is a medication I strictly use for vestibular migraines or migraines with brainstem aura, or hemiplegic migraine. So what is migraine with brainstem aura? It is the migraine with some brainstem symptoms. It could be something like tinnitus, ringing in the ears. It could be dizziness. It could be double vision. Um, it could be dysphagia, dysphonia. It could be any brain symptom. And it could also be a decreased level of consciousness or loss of consciousness with patients with migraine with brainstem aura. And I see that it's of most benefit in those kind of patients. And anti-seizure medications, Topamax is used a lot in our practice, but understanding we have to try to titrate them as long as they can tolerate to at least 100 milligram daily dose. See a lot of patients again who try 25 milligram or 50 milligrams and then just move on to the next medication. But again, understanding this level A evidence came from using at least 100 milligrams of Topamax, but it has a lot of side effects: cognitive slowing, brain fog, memory issues, some paresthesias. But have to be careful in patients who are young, of childbearing age, if they want to get pregnant. So we don't want to use that. And patients who have glaucoma, because it can trigger acute angle closure glaucoma, in history of kidney stones as well. Valproic acid also has level A evidence, but has a lot of side effect profile: hepatotoxicity, thrombocytopenia, weight gain, hair loss. Typically don't use gabapentin a lot. There's no clear evidence, but it can be used in patients with, who have neck pain, and that sometimes neck pain triggers them to have, it triggers their migraine. So I can use that in those kind of patients. There are some patients who Topamax works great it's a great medication but cannot tolerate the side effects. And in those patients, I use zonisamide, which is similar in mechanism of action, and usually patients tolerate that better than the Topamax. Lastly, there's more recent data to suggest that Keppra works for patients, especially in patients who are admitted to the hospital. You can use IV Keppra. I use that a lot with intractable headaches, where you've tried a lot of different things. You don't want to go to DHE or something stronger. You can always give them IV Keppra, but you got to give them at least 1.5 to 2 grams of IV Keppra in the hospital. But I've seen some great benefit and some great response with IV Keppra. And I'll just name these medications. These are CGRP antagonists. These are, again, work on your calcitonin gene-related peptide. Came out in the last 6-7 years, I would say. They can be once a month injections, or they can be every 3 month infusions. Like the eptinezumab, but other ones are the once a month injections. There is a more recent, that the FDA came up with, like you have to watch for hypertension with these medications. It's a class effect, so it covered it was not just for one medication. Something to be careful about. I've never seen somebody with, acutely increase, like put them in a hypertensive urgency if their blood pressure previously been controlled, but it can slowly increase their blood pressure, especially with adalimumab, which is Aimovig. I've seen it with them a few times. And lastly, Botox. It was approved with a trial called Preempt trial. You do 31 injections in the front, in the temporalis muscle, basically corrugator posterior frontalis and temporalis, and then you'll do in the back, in the trapezius, in the cervical muscles, cervical capitis. So you can do Botox every 3 months for patients with chronic migraine, more than 15 headache days, and usually we've seen very good response with Botox. So one thing to understand is, if you start somebody on Botox, you have to at least try it for 3 cycles, 3 or maybe even 4 cycles. So that means, having a discussion with the patients, like, hey, if you're going to start Botox, we cannot just jump to a different thing. If within a few months you don't see any improvement, you're kind of married to the idea of Botox for at least 9 months to a year. So that's very important that the patients have that understanding of, that if they're going to go towards that route of Botox, they have to be patient. Then we'll talk about tension type headaches. This is actually the most common headache that we see in regular in the world, but we don't see this as well in our clinics, because most of these patients don't need a neurologist. They don't need to come in. They don't need, unless they have chronic tension type headaches, or it just bothers them too much. It's usually like a band, like dull, mild to moderate. It's usually never severe, so you shouldn't. So if somebody's complaining about a severe headache, think about something else, and not just a tension type headache. Sometimes neck exercises, osteopathic, chiropractic manipulations can help. I don't suggest it. I don't suggest chiropractors too much, given risk of vertebral artery injury with chiropractic manipulations. And if treatment is required, I like amitriptyline a lot in these kind of patients, mirtazapine, venlafaxine, other things that we've used. Things to note: triptans, muscle relaxers, Botox, and opioids have no use in the treatment of tension type headaches. Okay. Next, we'll talk about trigeminal autonomic cephalgias. And I think the important thing here is the word autonomic. So these cephalgias would mostly be in V1 distribution or temporal. So that's something that should distinguish them with trigeminal neuralgia. So trigeminal neuralgia, on the other hand, would mostly be V2, V3 distribution, pain predominantly on the face. I mean, it can be V1 as well, but that's going to be a little bit, you got to think about it again. If you diagnosing somebody with trigeminal neuralgia and they have predominantly they have their pain in the V1 distribution, you got to think about and make sure you have the right diagnosis. So V1 or temporal onset of sudden, it's a severe onset of pain. And when we talked about migraine, the timeline for migraine, so that's why it's so important. And I ask when I cannot understand, what exactly are they having? They're complaining of these severe stabbing headaches, and I usually ask them, okay, if you don't take anything, how long they last for? If they last for like an hour, it's usually not migraines. That's where you have to start thinking about cluster headaches. And the other thing I ask them, what do you do when you get a headache? A lot of patients, uh, that would be one of the distinguishing features with these cluster headaches and migraines. Patients with migraines will tell you they want to lay down, whereas patients with cluster headaches, they will tell you that they just like walking around. They're like very agitated. That's why it's called suicide headaches as well, because these headaches are so severe. So asking patients what do they do when they get these headaches is very important sometimes to distinguish, and make sure we're not calling cluster headaches migraines or migraines cluster. Um, so when it comes to autonomic symptoms, people can have conjunctival injection, tearing, nasal congestion, rhinorrhea, eyelid edema, ptosis, meiosis, facial sweating, forehead sweating. So if somebody has sharp, um, severe, short-lasting headaches, and they have autonomic symptoms. And so you have to think about trigeminal autonomic cephalgias, cluster headaches, and other kinds. And we'll talk about the other kinds as well. And if they don't have autonomic symptoms, then you want to think about more like trigeminal neuralgia route. um, so, yeah. Uh, Cluster headaches, which is again the most common kind of trigeminal autonomic cephalgias. It can be chronic cluster headache or episodic cluster. How do you distinguish between them? If somebody has a pain-free duration of more than a month, so which means if they have clusters of these headaches, and between the clusters there is it takes more than a month between two clusters, then they have episodic cluster headache. And if it takes less than a month, and within 2 weeks or 3 weeks they go into another cluster, then it's chronic cluster. And the treatment is different, where for episodic cluster, you don't want to put them on preventative medication, because what if they have cluster once a year, right? Using medications like lithium might be an overkill. And those patients, you will just tell them, okay, call us when you get a cluster headache. You use a steroid taper at the start, and making sure steroid taper is not just a Medrol dose pack, or you see those dose packs out in pharmacies. We want to make sure that we put them on the right dosing, and that's why it's very important. 80 milligram for 5 days, and then we go down from that 80 milligram every 10 days, and it's supposed to shorten their cluster. And you can also use medications like Emgality, which is a CGRP antagonist. You can use that at the start of their cluster, and then monthly till the end of their cluster. Or you can use lithium. If somebody has chronic cluster, verapamil is proven to be more effective. Now, as far as needed medication, so a lot of these patients will have headaches for only 15 minutes. So, making sure when it comes to triptans, subcutaneous triptan was found to be way more effective than oral, and even intranasal sumatriptan and intranasal zometriptan was found to be way more effective than oral medications. You can also, if they're in the ER, you can use high flow oxygen, so making sure they are using a non-rebreather high flow. It's at least 12 liters per minute for at least 15 minutes, and that works very well. Sometimes we prescribe oxygen to patients as well as a rescue to take at home, but you have to be very careful. They're not a smoker, nothing, it doesn't, it's a dangerous situation if they're a smoker and they're lighting stuff around oxygen. Um, you can also use intranasal lidocaine as well, which is the second line. I would not go in a lot of detail of other trigeminal autonomic cephalgias, but just to understand a few of them, we talked about cluster, but there's something called hemicrania continua, which means it's usually a side-locked headache. It's also, again, a stabbing, throbbing headache. It's in the orbital frontal temporal region, like we talked. But the important part here is to, and it can also have autonomic symptoms, but important part here is that it's a continuous pain which never goes away. So it's always side locked on one side, and they have it all the time. It never completely goes away. So that distinguishes it with the cluster headaches. Where the cluster, it's 15 minutes to 3 hours, and the pain will completely go in 3 hours. Hemicrania continua is an endomethacin responsive headache. So you want to give them at least 75 milligrams of endomethacin daily, and it should take the headache away completely. So, understanding this headache disorder is so important, because these patients will come to you. They've had pain for years and months, and it never goes away. And you give them endomethacin, and it just completely takes it away. There is no pain after endomethacin, but you got to give them a good trial, at least 75 milligrams daily. Give them for a few days, and if that doesn't work, go to 150 milligrams or higher. Sometimes 220 up to 225. You got to give them a good trial of endomethacin. And there's another class of medication, Sunkersuna, which is, again, they're trigeminal autonomic cephalgias. But the important thing that distinguishes it from other headaches is this duration of headache is usually 1 second to 10 minutes, and you can have up to 200 of them a day. Again, similar to cluster, just biggest difference is the duration of the headaches, whereas if it's less than 10 minutes, it's Sankarsuna. If it's 15 minutes or more, up to 3 hours, it's cluster. And patients, what is SUNC? It is short-lasting unilateral neuralgiform headache with conjunctival injection and tearing. And what is SUNA? It's short-lasting unilateral headaches with neuralgiform headaches with autonomic symptoms. So SUNC or SUNA, based upon their duration, you can diagnose with them if they fit the right criteria. You can use lamotrigine, oxcarbazepine, topiramate, or gabapentin. Medication overuse headaches, I think that should be very high on the radar, especially with any new patient who comes to your clinic with chronic headaches. A lot of times I see patients coming with, they think they have chronic headaches, they have more than 15 headache days or 20 or even everyday headaches. And all you do is you get rid of these NSAIDs, Tylenol or acetaminophen, opiates, Furosemide, and it just, they go from everyday headache to maybe 1 or 2 headaches a month. So I think that's one of the biggest things to rule out when somebody is coming in with new patient with chronic headaches, or even your older migrainer. If they're like, okay, my headaches are so much worse now. I used to have them twice a month or 4 times a month, and now I have them every day, or now all of a sudden became chronic. Maybe there's something happened and they started using more and more and more of these over-the-counter medications. For medication overuse headaches, when you stop these culprits, you will have significant rebound. So sometimes I bridge them with tizanidine or naproxen for a few days. I know we said naproxen and there's an NSAID in this. A lot of times patients not using naproxen as their NSAID of, as a culprit. I'll use naproxen as a bridge. like 500 milligram daily for 7 days or 8 days, or prednisone taper. Prednisone taper, I usually use at least 80 start with 80 milligrams. So it has to be a high dose. So then 80 for 2 days, 60, 40, 20. But yeah, when we use prednisone taper for any medication overuse headaches, or even like as a bridge for short, patient can have short time worsening of their migraines um, during weather changes or something, you can use this as a steroid. You can use steroid taper, but making sure you give them enough steroids. Um, we'll talk about some painful cranial neuropathies. We talked about trigeminal neuralgias briefly, but again, it's usually V2, V3 distribution. It's a brief stabs. Every now and then we see patients who come with like severe pain on the face, and they deny having these brief stabs, excruciating pain. So what can happen is the pain can start off as these brief stabs, but sometimes it can transition into this severe, just chronic pain. Sometimes understanding that you have to ask, like, way back when this started, how these symptoms were, and there can be some significant triggers, like even drinking cold water, eating, speaking, brushing the hair, or brushing the teeth can be a trigger. Um, Anytime somebody comes with trigeminal neuralgia, I think getting in structural pictures for with MRI of the brain and MR angiogram to look for vascular compression of the cranial nerve is very important. Or stuff like multiple sclerosis, which trigeminal neuralgia can be a presenting symptom of multiple sclerosis. I see great benefit with carbamazepine, oxcarbazepine, lamictal, gabapentin, even baclofen works very well. And if nothing's working, sometimes people need surgical decompression, especially if they have a vascular compression of the cranial nerve with this. There are other kinds of neuralgias, neuropathies that we see. Occipital neuralgia, which is this pain that is like starts from the base of the skull. It's a shooting pain. It's a radiating pain. It goes towards the eyes. So we can use nerve blocks for this. Glossopharyngeal neuralgia, which is this unilateral pain, severe sharp pain located at the pharynx base of the tongue or the ear. Important to know about these different cranial neuropathies. Let me see. How are we doing in terms of time?
We have a few more minutes. You can
Okay,
continue.
got it. Okay. We will talk next about these other primary headache disorders. These are very rare, but every now and then we see them. I distinguish them based upon how long they last for. If they last for more than 4 hours, there's a category now called daily new onset progression of constant headaches, called new daily persistent headache. It is one of the most difficult headaches to treat. So basically what the patients will come with, like, hey, like 7 months, 5 months ago, one day they will tell you, I was at church this day, I remember this exact day, and I just started having headaches, and since then it has never gone away. That would be like the classic, presentation with new daily persistent headaches. I treat them based upon what they look like. If what they sound like, if they have migrainous features, I treat them with migraine medications. If they have tension type headache features, or sometimes you just have to try different medications, and it's one of the very tough headache disorders to treat. Sometimes patients will complain like there's this coin-shaped, sharp headache, which last for many, many hours. It's called nummular headaches. And if it's lasts for more than 4 hours, you can distinguish them based upon some triggers. They can be primary cough headache, primary exercise headaches, primary sexual activity headaches. But anytime somebody comes with primary sexual activity headaches or primary cough headaches, one thing you have to rule out is a brain aneurysm. I think that's very, very important to understand. Other things are, there are some other stimulus headaches, like external pressure headaches, and cold stimulus headaches, like something called ice cream headache. You eat ice cream too fast, that can trigger a migraine for you. There's something called primary stabbing headache, which is just this brief, irregular jabs. And the important thing here is it's not side locked. Anytime you have a side locked headache, I think it's very important to rule out a structural problem, an aneurysm or a brain tumor or something. Anytime, these patients will be like, okay, I can have stab here, here, all parts of the head. There can be something called primary thunderclap headache, which presents as a migrainous, brain aneurysm or a subarachnoid hemorrhage, which is like sudden onset 10 out of 10 headache. But it can still be a primary headache, which means there's no aneurysm and it just happens, and you have to treat it with maybe things like verapamil, canceled calcium channel blockers. Lastly, there's a headache disorders called hypnic headaches. Usually, these older patients will come to you and you'll be like, every night I wake up at 2 a.m. or 3 a.m. with this headache, and it's like an alarm clock. They don't ever have them during the day. They just have them at night. And surprisingly, though, what works the best for these kind of headaches is drinking coffee, or taking a caffeine tablet an hour or so before going to bed, usually should get rid of these kind of headaches. So what I'll do is I'll talk about we'll talk about headaches in pregnancy as a last thing, and I do want to leave a few minutes for questions. I think I just have a few slides. We won't go over secondary headaches. We'll just focus on primary headache disorders today. I know there's a lot to cover, so patient you may have patients who come to you for the first time during pregnancy. Now, a lack of headache history is associated with nearly like 5-fold risk of developing a secondary headache. So things that you have to be very careful. If they've never had headaches and they have headaches during the pregnancy, it's a red flag. You have to, you have to look into that more detail, maybe do some kind of imaging, and tension type headache is the most common form of headaches in pregnancy. But again, if they do not have a history of headaches, you want to be very careful with somebody who presents, because especially in third trimester, because that's patients after 20 weeks, they're very high risk for developing a durovenous sinus thrombosis or dissection as well. Other things to be careful with headaches would be, do they have eclampsia, do they have preeclampsia, what their blood pressure is, what their urine looks like. So that's again something that's very important to consider in new headaches during pregnancy. Other syndromes or other headache disorders can be posterior reversible encephalopathy syndrome, reversible cerebral vasoconstriction syndrome, pituitary apoplexy, and post-dural puncture. So patients have, they deliver, they had an epidural and it did puncture the dura, and now they have a CSF leak, so they can have a post-dural puncture headaches. These patients will present with headaches, and they will have a low pressure headaches, which means the headaches will completely sometimes completely go away. Sometimes it would significantly reduce when they lay down. So a low pressure headache after they deliver, it's very high. You've got to think about post-dural puncture headaches and CSF leak. Let me see. Abortive medications in pregnancy. Things I use a lot is lidocaine, metoprolol, and Tylenol. These first three things are the things that are most effective and most safe out of everything else. I can also, most recently there has been more and more safety data with triptans, and I've been less conservative when using triptan in pregnant patients. And even I think the OBGYNs right now, they're more, they've been using, I've seen that they've been using triptans as well for patients with headaches and migraines during pregnancy. And as I said, there's no data to suggest that they're unsafe during pregnancy. Anything else like, these G-PANs or lesmididine or Furosemide and all other kinds of medication, you have to be very careful with pregnancy. Preventative medication, I use propranolol a lot, magnesium, memantine, and coenzyme Q10. sometimes I do use amitriptyline depending upon risks and benefits. But when it comes to Botox, if they've been on Botox, I can still consider keeping them on it. But if they've never tried Botox in the past, I would not start a pregnant patient on Botox. But yeah, these are the other medications that you should not use as a preventative medication in pregnancy. Okay. So I what I'm going to do is I'm going to stop here and take questions because I want to leave a couple minutes for questions as well. Um, so
Okay, thank you, Dr. Mann, for such a wonderful presentation on headaches, a very, very important topic. We see patients often with this complaint, so it was very refreshing to get an overview, an update on the management of the various headache disorders. So the floor is now open for questions and or comments. You can feel free to place your question or comments in the chat section for Dr. Mann. And while you think of your questions and comments, I just want to remind everyone that this is accredited CME. So please to ensure that you have your name as recorded by the medical council, written out clearly, as well to ensure that you complete the feedback for this presentation. So we have a comment saying, thank you for your thorough presentation. Thank you, Dr. Bodie, for your comments. Do we have any questions for Dr. Mann? Or everyone has completely absorbed everything that was presented this morning? Okay, I see a raised hand. I acknowledge your hand, Dr. Frankston. You can go ahead.
Hi, good morning. Thank you for a very handy presentation today. I'd just like to ask, what is the room for in prevention and also in enhancing recovery? What's the room for lifestyle modification in relation to headaches?
yeah, that's a great question. So um, now there can be some very clear triggers when it comes to migraines, and I think there are some triggers that we can definitely work towards. Like every time I see somebody with migraines, the first time we go over a lot of other uh, triggers that they may have. We talk about caffeine intake. We talk about their work. Are they doing like shift work where they're doing like a day shift and night shift and all, but a lot of times I've seen is there are some triggers um, that we cannot do. Life happens, right? So they're shift workers. What are they going to do, right? They have to, life happens and they have to continue what they're doing. So sometimes we work on just making the headache better with medication. Obviously, in an ideal world you want to look at all their triggers, and weight loss, exercising, making sure what how much caffeine they're drinking. They go to sleep and get at least 8 hours of sleep. Those are all important things. But as I said, real world is, like all of us know, real world is very different. The triggers, if they have those kind of clear triggers that you can work on, yes, we do that. But again, sometimes it becomes more stressful for patients to track their triggers. A lot of times I see patients like, oh, I made a whole diary of what I'm eating and everything. Then actually that induces more stress and causes more migraines in some of our patients. So yes, if you have clear, if clearly you can make changes to your eating habits and stuff. But I don't like them to go and dig in and start eliminating one thing from their diet and trying to figure out. That's usually very stressful for most of our patient in real world. Yes, ideally, yes, we should do that. Um, there's a question, I think, it says any changes in incidence, headache incidence after COVID. Yes, we have seen. I think we've realized that after COVID, there's a big increase in anxiety and depression. So is it linked to that? I think it can be. But I don't know if your question was like a post-COVID headaches. Yes, we've seen that a lot as well. Post-COVID, you can get headaches, and usually you treat them based off what they fit into. Like, is it a new daily persistent headaches? Are they more migrainous headaches? So you treat them that way. But we do see a lot of long haul COVID, and they can have headaches with it as well. Um, I see most of those patients as more like a tension type headache presentation, but again, it can trigger any other kinds of primary headaches as well.
Okay, thank you. We have another question there that is stating that there's a lot of information regarding headaches. Is there a cheat sheet or an algorithm card that can be used for quick diagnosis?
Um, I will have to look at it. As I said, it's just I did share my presentation, so if that helps anybody, it can be shared. So that should be available. But again, I understand that this is a lot of information. At least having those treatment options available. I think you can just. But I do not have a cheat sheet that I use, but we can certainly look into one, and I can share some if I find something that would be helpful.
Do we have any other question for Dr. Mann? Okay, I don't see any. Oh, we have another thank you for your presentation posted inside the chat. And Dr. Bodie thanks you for your response to her question earlier on the incidence of headache post COVID. Okay, if there are no additional questions, I would like to take this time again to extend our sincere appreciation for you taking time out of your very busy schedule to inform us, educate us, and update us on information regarding headache disorder. Thank all of you for attending this session of continuing medical education. You would have just leveled up your knowledge and you are well equipped to get back in the hospital and the clinics and give the very best evidence based treatment for all of your patients. Until next time, I will see you at our next CME, which will be the last Friday of this month. Have a great day.